Hello, this PowerPoint will discuss Attention Deficit Hyperactivity Disorder, also known as ADHD. This presentation will be done by Sheila Bolfa, Catherine DeVilliers, and Isabel Dubois. Here are your presenters for this PowerPoint, Catherine, Isabel, and Sheila. This table gives a list of abbreviations used throughout the presentation. Upon completion of this presentation, learners should be able to understand and identify risk factors for the development of ADHD, as well as the prevalence of the disorder. Learners should also be able to analyze the neurobiology behind ADHD. The third learning objective is that learners should be able to understand and describe the diagnostic criteria necessary for a diagnosis of ADHD. And finally, be able to understand and recognize how and when to apply recommended interventions for those with a diagnosis of ADHD. Before we begin, let's review a few questions to assess your baseline knowledge surrounding a diagnosis of ADHD. Question number 1. While risk factors for ADHD continue to be researched, which of the following has not been shown to be one of the risk factors? A. Premature birth. B. Substance use during pregnancy. C. Lead exposure during pregnancy. Or D. Folic acid supplementation during pregnancy. Question number 2. ADHD is one of the most common neurodevelopmental disorders in children. Which of the following statements is true about ADHD? A. Girls are more likely than boys to be diagnosed with ADHD. B. Children between the ages of 3 and 5 years old are the most at-risk age group. C. Children with ADHD rarely have comorbid mental health diagnoses. D. Adolescents between the ages of 12 and 17 years are the most at-risk age group. Question number 3. Which of the following is a recommended treatment for ADHD? Select all that apply. A. Inpatient hospitalization for immediate medication management. B. Behavioral therapy. C. Medications for all children beginning at the age of 3. D. Involving the school. Or E. All of the above. Question number 4. Which of the following is not part of the DSM criteria for ADHD? A. Inability to sit still. B. Forgetful. C. Difficulty listening when spoken to. Or D. Loss of interest. ADHD is one of the most common neurodevelopmental disorders that providers see in the outpatient setting. It is considered to be a chronic disorder that can cause symptoms well into adulthood. This disorder was first described in 1902 by George Still, who described children as being impulsive, restless, and having poor attention spans with behavioral problems. The symptoms of ADHD lead to academic and social impairments. This disorder can have 3 different presentations. These presentations include inattentive type, hyperactive or impulsive type, or a combined presentation. These presentations will be discussed further in this presentation. It is estimated that ADHD affects up to 10.2% of children worldwide. It occurs more often in males than females at a ratio of 2 to 1. The prevalence may be affected by cultural attitudes towards certain behaviors. Females are more likely to present with symptoms of inattentiveness compared to males. We will start by reviewing the diagnostic criteria necessary for a diagnosis of ADHD, primarily the inattentive type. The inattentive type involves 6 or more of the following symptoms that have persisted for at least 6 months that result in impaired social, academic, or occupational activities. These patients often fail to pay close attention to details and may make careless mistakes in their work. They often have difficulty sustaining attention in certain tasks or play activities. They may struggle with listening when spoken to. They may have difficulty following through on instructions and fail to finish their work on time. They may have difficulty organizing tasks and activities. They may avoid or dislike or be reluctant to engage in tasks that require sustained mental effort. They may lose things that are necessary for certain activities, such as school material, wallets, keys, and their telephones. They are often easily distracted by external stimuli, and they may be forgetful in daily activities. Diagnostic criteria for ADHD with the hyperactivity and impulsivity criteria involve 6 or more of the following behaviors that have persisted for at least 6 months. These patients may fidget, tap, or squirm. They may have difficulty staying in their seat. They may run or climb in situations where these behaviors are not appropriate. They may be unable to play or engage in leisure activities. They're often on the go or act as if they're driven by a motor. They may talk excessively. They may blurt out answers before a question is finished. They may have difficulty waiting their turn, and they may interrupt or intrude on others. Other criteria for a diagnosis of ADHD include the following. Several of the behaviors should be present prior to the age of 12. The symptoms should also be present in 2 or more settings, such as home, school, work, or with certain relatives. There should also be clear evidence that the symptoms interfere with or reduce the quality of their social, academic, or occupational performance. And the symptoms don't exclusively occur during the course of schizophrenia or another psychotic disorder. Individuals with ADHD often have multiple comorbidities. Females have higher rates of comorbidities like oppositional defiant disorder, autism disorder, personality disorders, and conduct disorders. Up to 50% of patients with the combined presentation of ADHD have oppositional defiant disorder. Conduct disorder occurs in about 1/4 of patients with the combined presentation of ADHD. Anxiety disorders, mood disorders, obsessive-compulsive disorder, and intermittent explosive disorder occur more often in those with ADHD than in those individuals without ADHD. Learning disorders, like specific learning disorder, autism spectrum disorders, intellectual developmental disorder, language disorders, tic disorders, and developmental coordination disorders may be seen in those with ADHD. Sleep disturbance are not uncommon. Individuals with cognitive impairments, like inattention, may present with sleep issues. Individuals with ADHD often report increased daytime sleepiness. Individuals with ADHD often meet criteria for hypersomnolence disorder. Other sleep disturbances include restless leg syndrome, insomnia, impaired circadian rhythm, and sleep-disordered breathing. Medical conditions that are more common in those with ADHD include allergies, autoimmune disorders, and epilepsy.
It is thought that the dysregulation of norepinephrine and dopamine are the main neurotransmitter responsible for ADHD symptoms. The hyperactivity or motor symptoms originate from a low concentration of dopamine and norepinephrine in the prefrontal cortex. The impulsivity would also originate from a low concentration of dopamine and norepinephrine in the orbitofrontal cortex. The cognitive symptoms can be divided into 2 problems, which are difficulty with selective attention, which originates in the dorsal anterior cingulate cortex, but also difficulty with sustained attention problem solving, which originate in the dorsolateral prefrontal cortex. As a result, dysregulation in some areas of the prefrontal cortex and orbitofrontal cortex can explain why ADHD has often comorbid symptoms with conduct disorder, bipolar and anxiety spectrum, as well as oppositional defiant disorder. Let's focus on the role of norepinephrine in ADHD. Norepinephrine prevents the loss of information and improves the signal if it binds to the alpha-2A receptors. In the prefrontal cortex, if norepinephrine is too low, it leads to cognitive dysfunction and inattention. If the norepinephrine is too high in the prefrontal cortex, it leads to increased stress levels, anxiety, mania, and substance use. So the goal is to have a moderate firing of norepinephrine and find the right amount to improve cognitive functioning, which is going to be manifested by an improved attention, concentration, better emotion, and impulse control. Now let's focus on dopamine and its role in ADHD. When the dopamine binds to the D1 receptors, the information gets lost and there's a weak signal. When the dopamine in the prefrontal cortex is too low, it leads to cognitive dysfunction. When the dopamine in the prefrontal cortex is too high, it also worsens cognitive functioning. Dopamine in prefrontal cortex can be increased by stress, anxiety, manic symptoms, and substance use disorders. Drugs can also stimulate dopamine. If we increase the dopamine intermittently when the pertinent information comes in, we reinforce the learning and rewarding events. To control ADHD symptoms, the goal is to increase the intermittent firing of dopamine.
Genetics have been found to play a role in the development of ADHD. MRI studies have found reduced gray matter volumes in those with ADHD as well as in siblings without ADHD. First-degree relatives of children with ADHD are up to 8 times more likely to develop the disorder. Children born to a parent with ADHD are also more likely to have ADHD. Dietary influences on the development of ADHD are controversial. Some studies have found a relationship between the development of the disorder and certain nutrient deficiencies, including iron, zinc, and fatty acids. Some children have behavioral effects due to food sensitivities like excess sugar intake. While studies have been conducted to review this, more research is needed. Neurotransmitters involve epinephrine, norepinephrine, and dopamine. Imbalance of these neurotransmitters are thought to play a role in the development of ADHD. Environmental factors are also something to be considered. Risk factors during pregnancy may increase one's risk for developing ADHD. Risk factors including alcohol, nicotine, or drug use during pregnancy, as well as the administration of glucocorticoids during pregnancy, may play a role. Poor maternal diet, as well as maternal stress, may also play a role. Perinatal ADHD risk include prematurity, low birth weight, and complications during delivery. ADHD has been found to be associated with certain childhood illnesses, including encephalitis, heart disease, thyroid disease, head trauma, autoimmune disorders, and meningitis. Elevated blood lead levels have also been linked with a diagnosis of ADHD. Psychosocial considerations such as poverty, abuse, poor parenting, family stress, and bullying have also all been associated with ADHD.
This slide will review some of the common screening tools that are used when making a diagnosis of ADHD. The first one is the Conners Abbreviated Symptoms Questionnaire, which is copyrighted and for purchase. And the second is the Vanderbilt Parent-Teacher Rating Scale. We do have links included for your review. The Vanderbilt is a free rating scale that is available online. ADHD can be treated in a number of pharmacological and non-pharmacological ways. In this presentation, we will discuss psychostimulant and non-psychostimulant medications, as well as behavioral interventions, complementary and alternative methods, and most importantly, the collaborative educational needs with the parent and child. The following slides are not all inclusive of all treatments that are available, however. Years of research have proven the safety and efficacy of stimulants to treat ADHD. They remain the first-line medication to treat this disorder. The therapeutic effects of these medications are to reduce the presentations of hyperactivity, impulsivity, and inattention in the affected individual. They can also improve the overall behaviors that interfere with daily functioning and development. Stimulants are known to be abused and for dependency to occur, which is why the FDA has classified them as a Schedule II narcotic. Stimulants come in two different forms called methylphenidates, or MPH, and amphetamines. They're classified as stimulants due to their ability to increase activity in the central nervous system. This is the reason that you see the increase in blood pressure and heart rate in any form of stimulant. We still have a lot to learn about ADHD, but what is ultimately seen is a lack of dopamine and norepinephrine, especially in the prefrontal cortex of the brain. Both MPH and amphetamines' primary action is to increase dopamine and norepinephrine at the synapse by blocking their reuptake. Amphetamines also have a secondary function of promoting the release of dopamine by reverse transport. In this slide, we will discuss the methylphenidates, which are respectively called MPH and DMPH. What differentiates these two formulations are its isomers. An isomer simply refers to the chemical compound of the medication. So they share the same formula, but the atoms of the molecule have a slightly different arrangement. And the difference in this arrangement gives the isomer a different property. In MPH, you see the D and the L isomer, and in DMPH, you only have the D isomer. These isomers affect the potency of the binding to the dopamine and norepinephrine transporters. And it's important to know the difference because the D isomer is the more potent of the two, ultimately making the compound itself more potent, which will give it a longer duration of action. These are some of the more common trade names for MPH. As you recall, the formulation that has both the D and L isomers. They come in immediate and extended forms and all have pretty early peaks and onset of action, which are usually between 30 minutes and 2 hours, except for the transdermal option Daytrana and the extended capsule Jornay. You will also notice the Jornay is a bedtime medication with a very late onset or peak, making the choice of giving a daily morning medication, twice daily medication, or even a bedtime preparation is a choice that the practitioner should make with the parent and child based on their individual needs. With all medications, and this will fall true for all the following slides of medications, the practitioner should always be aware of those little pearls of knowledge regarding medications, especially when to avoid the medication due to structural heart disease. There are also implications of whether to take it with or without a meal due to absorptive or metabolizing properties. You will see in this slide specifically that there are highlighted trade names. These trade names have been around for a long time, and you will either hear of them in practice or you've heard of them before. These trade brands are no longer available either in the US or at all. And also, Concerta has recently had their manufacturer in its generic form. I believe this was in January of 2023. So only the trade brand is available, which may end up having cost concerns if prescribed. The DMPH formulations are the immediate release Focalin and the extended release Focalin XR. These only contain the D isomer, making them a more potent form of the methylphenidates. They are available in daily and twice daily forms, and a little pearl is to avoid antacids with them. A dosing tip for methylphenidates in general is that you may possibly be able to prescribe the medication during the school week only and give them drug holidays during summer breaks, etc. But these would need to be individually assessed with each patient. Amphetamines are the second group of stimulants. They hold the same concept of isomer compounds as the methylphenidate class. Amphetamines with D and L isomers are known as mixed salts. They have equal potency on sodium binding. D-amphetamines only have the D isomer, which sets them apart from the mixed salt versions, and they're more potent form of amphetamines with stronger stimulant properties. Another newer version of amphetamines are the Lisdex amphetamines. These are D-amphetamine prodrugs, and they are linked to the amino acid lysine. The molecules are cleaved or split in the stomach, and they turn into D-amphetamine, and they are slowly absorbed rather than the rapid absorption of the other amphetamines. Again, the difference in the amphetamine class is simply a difference between its isomers. Both are dopamine norepinephrine reuptake inhibitors. D and L isomers are mixed salts, will have more action on dopamine norepinephrine binding, but this does not make them a stronger drug. Dextroamphetamine is more potent because it only contains the D-amphetamine isomer, making it the more potent drug. So in essence, more action on two neurotransmitters does not equal more potency. The mixed salts are a highly recognizable medication known as Adderall. It comes in an immediate and an extended release version with a significant difference in peak and duration. Adderall immediate release can be prescribed for children as young as 3 years old. D-amphetamine formulations come in extended and immediate release, as well as the lisdexamphetamine formulation. Dexedrine is likely considered the most potent amphetamine made. The immediate release tablet Zenzity can be prescribed for children as young as 3 years old. Vyvanse is a widely known trade name on the market and is the lisdexamphetamine formulation. Just be mindful that this particular medication does have a structural heart disease disclaimer. The benefits that are evidenced in the use of psychostimulants have been recognized more in the behavioral domain rather than the cognitive domain of functioning. Overall, you see the reduction of gross motor activity and improvement in the disruptive behaviors, as well as an increase in the academics, productivity, reaction times, short-term memory, and the learning of verbal and nonverbal material. These are some of the more common, infrequent, and rare adverse effects of stimulant medications. These are considered more short-term adverse effects. Be mindful that these effects do not necessarily mean that a medication needs to be stopped. Sometimes the medications can be adjusted by changing the dose or the time, or even an adjunct medication can be given to decrease the symptoms. With the rare adverse effects, discontinuation of the drug may be warranted. Growth and substance abuse fall under the category of the more long-term complications of stimulant drugs. Growth suppression in the first year of treatment has been associated with these drugs, but studies have not produced enough evidence to conclude this. Growth disruption is thought to be due to either reduced caloric intake, which is seen with stimulants, the actual disorder of ADHD itself, or possibly effects on growth hormones or prolactin. Because of this, it is imperative that height, weight, and BMI be monitored before and during therapy. We spoke earlier about substance abuse with stimulants and the fact that it is listed as a Schedule II drug by the FDA. There has been no clear evidence of abuse with long-term treatment with stimulants, and it's actually thought to have more of a protective effect on the individual with ADHD in decreasing the potential of abuse due to its therapeutic effects on behavior and function. However, it is recommended that the practitioner always take into consideration family substance abuse prior to prescribing a stimulant due to the possibility of diversion. Consideration of non-stimulant medications are available for those who do not respond well to stimulants. Two non-adrenergic formulations are Strattera and Wellbutrin. Strattera is a selective norepinephrine reuptake inhibitor, and it is also known for its antidepressant properties. It is approved for use in ADHD by the FDA for 6 years old and older only. Wellbutrin is a widely known antidepressant and is a norepinephrine dopamine reuptake inhibitor. It is a medication with an off-label use for ADHD, and it does have a black box warning of lowering the seizure threshold. Alpha-2 agonists are drugs commonly associated with management of hypertension. The alpha receptors are very highly concentrated in the prefrontal cortex, which is where ADHD is thought to be most commonly affected. Two alpha-2 agonists that have been used in the treatment of ADHD are guanfacine and clonidine. Both drugs stimulate postsynaptic receptors, which increases norepinephrine back to normal levels. And there's low potential for abuse with these drugs due to having no action on dopamine. Guanfacine and clonidine are very similar in their actions, but guanfacine is more selective for the alpha-2A receptors, whereas clonidine is non-selective on alpha-2A, B, and C receptors. Both controlled release formulations are approved to treat ADHD, and both have off-label uses to treat conduct and oppositional defiant disorder, as well as Tourette syndrome. Because guanfacine is selective for alpha-2A receptors, you will have less of the sedative effects seen with clonidine, which has increased side effects due to the non-selective action on the alpha-2A, B, and C receptors. You would be more likely to see things such as sedation, headache, hypotension, syncope, or even bradycardia with clonidine. Guanfacine is also used as an adjunctive medication to stimulants in patients with oppositional symptoms. Guanfacine formulations are Intinib, which is approved by the FDA for monotherapy and adjunctive therapy, while Tenex is an immediate release that is used off-label. Capvey is the extended release clonidine and is also used for monotherapy and adjunctive therapy, while Catapress immediate release is off-label use. Tricyclic antidepressant studies do support the fact that there is symptom reduction of ADHD with their use. However, extreme caution should be used when prescribing them. TCAs are known to have serious side effects such as cardiac dysrhythmias, slowed conductions, blocks, or even sudden cardiac death. They also lower the seizure threshold and have very uncomfortable cholinergic side effects such as dry mouth, constipation, and blurred vision. If TCAs are used and discontinued, the practitioner must practice safe tapering over several weeks. Some of the TCAs used are listed in this slide. A new treatment that is a selective inhibitor of norepinephrine transporter is Quellbri. This medication is also known to have action on serotonin receptors. There is research looking into the possible link of serotonin and ADHD, but nothing is conclusive to date. Quellbri mimics the action of stimulants by increasing dopamine and norepinephrine, but has less side effects than the stimulant. It was approved by the FDA in 2021 for children 6 to 17 years old. There are numerous behavioral interventions that work well as non-pharmacological treatments for ADHD. They are used as monotherapy as well as adjunctive with medications. Parent training behavior management is the recommended first-line treatment for preschool-age children, even prior to medication. Parents are able to learn age-specific development expectations. They're given tools to improve their relationship with their child, and they're also taught how to manage specific behaviors. Behavioral classroom interventions, known as IEP, or Individualized Education Program, has been developed for special education needs of students and is actually a law in all public school systems. The IEP programs offer individualized instructional support in the classroom. Cognitive behavioral therapy is recommended when medication has benefited the patient, but there's still underlying cognitive or behavioral problems. CBT is beneficial in restructuring the maladapted cognitive and behavior patterns. These treatments are not all-inclusive of all methods out there. The type of therapy required is based on the individual need of the patient, and they may need something other like social skills training, individual therapy, special behavior modification practices, or simply psychoeducation. One of the most simplistic alternative treatments for ADHD is physical activity. The reduction in dopamine and norepinephrine in ADHD is indicative of poor cognitive function. Studies have actually shown that when catecholamines increase, there is an excitement of neurotransmission, which will lead to the overall improvement in executive function. Improvement has actually been seen in disorders such as anxiety, depression, aggressive behavior, and overall social skills when physical activity is increased. Again, these slides are not all inclusive of all the treatment modalities for ADHD. However, one complementary or alternative method is trigeminal nerve stimulation, which actually gained FDA clearance in 2019. The process is non-invasive and is performed on children 7 to 12 years old, but only with the supervision of a caregiver. The device does generate an electrical signal, and it has low-level stimulation to the trigeminal nerve branch. It's thought to increase activity in certain portions of the brain and has been shown to regulate the executive function that is impaired in ADHD.
Benner's learning theory, named from novice to expert, has been used to evaluate learning in various settings, whether it is preceptorship or training. In this case, this theory was simply used to evaluate the knowledge retained in specialized training like this one. It is a model of skill acquisition and skill development. There are 5 levels of nursing practice: novice, advanced beginner, competent, proficient, and expert. Novice nurses tend to rely on concept and principle, while expert nurses rely a lot on experience to guide practice. Novice nurses tend to consider all elements as equally important, while expert nurses give them a different level of importance. Novice nurses tend to be more detached, while the expert nurses tend to be more engaged and involved in the process. As nurse practitioners, we are expected to be more than competent. We are expected to be proficient and expert. Competency development is the goal of this presentation, but it is also a major component of our master's program.
Now that our presentation is complete, let's review our pretest questions and see how much you've learned. Number 1, while risk factors for ADHD continue to be researched, which of the following has not been shown to be a risk factor? The answer here is D. Folic acid supplementation during pregnancy has not been shown to be a risk factor for ADHD. Substance use, lead exposure, and premature birth have all been shown to affect the prevalence rates of ADHD. Question number 2. ADHD is one of the most common neurodevelopmental disorders in children. Which of the following statements is true about ADHD? The correct answer here is D. The most common age group that receives a diagnosis of ADHD are adolescents between the ages of 12 and 17. Boys are more likely than girls to be diagnosed with ADHD at a ratio of 2 to 1. Children between the ages of 3 and 5 are not the most at-risk age group, as this is a difficult time to distinguish between normal behaviors as well as ADHD behaviors. Children with ADHD often have comorbid mental health diagnoses. Question number 3. Which of the following is a recommended treatment for ADHD? This is a select all that apply question. The correct answer here is B as well as D. Inpatient hospitalization for immediate medication management is not the best option. While some patients may need medication management, this is not first line. Behavioral therapy and school involvement are both important components of treatment for children with ADHD. Medications for all children beginning at the age of 3 is not an appropriate response. Many medications are not approved until the age of 6. Question number 4. Which of the following is not part of the most recent edition of the DSM criteria for ADHD? The correct answer here is D. Loss of interest is associated with mood disorders, not ADHD. Inability to sit still, forgetfulness, and difficulty listening are all common criteria that are seen in children with ADHD. Thank you for reviewing our presentation, and we hope you learned something new and beneficial regarding ADHD.